So with that, as the last speaker of the day, I hopefully this can be a nice way to end the day with some maybe not all great news, but at least some hopeful news. And we will finish on time. So with that, I'm going to, as you know, speak on loneliness and social isolation among older adults, specifically gearing that toward persons with cognitive impairment. Here's our disclosures. We too have a geriatric workforce enhancement grant. And I want to thank the founders of the intervention I'm going to talk with you about from the University of Helsinki in Finland, and for Max Sabatsky, who you met earlier today. What we'll be covering in the next 45 minutes or so really is to address the issues of what are loneliness and social isolation, how prevalent are they, and then what are the special and maybe possibly unique aspects for someone who has cognitive impairment and their caregivers. We cannot forget the caregivers. Talk a little bit about what this has been like for this population during the pandemic. And then I want to share with you some interventions, some of which I have experience with, others not. So, and to also, I'll kind of weave in a little bit about age-friendly health systems, because I know we all. So, as promised, I want to start out and kind of establish what are these things. I was attending a webinar last summer now, actually, almost a year ago. And this quote was just so poignant, I thought. Jane Sachin referred to this as an epidemic in plain sight. And I thought, oh my gosh, that could not be more appropriate. So let's set the stage by making some definitions. The terms loneliness and social isolation are used interchangeably. And in fact, they're quite different. I've noticed, especially during the pandemic, where these issues get talked a lot about, they're woven together in a confusing way, quite honestly. So loneliness, if you think about it as a subjective or qualitative kind of experience, it's actually when the expectations that we have for relationships are not met. So it's that disconnect between what we hope for and what the actuality is. Whereas social isolation is a quantitative or objective accounting, if you will, of the actual number of contacts that we have with other humans in a given period of time. They overlap, which I think you'll see here shortly, but they really are two distinct kind of experiences, and they're very unique. Both of these are so individualized because one person may not, they may have a similar experience, but not feel lonely. So a little bit of background on this. Believe it or not, this was an issue before COVID became part of our world. In 2017, in fact, Vivek Murthy, who's a former US Surgeon General and was appointed to Biden's COVID team, actually, called it a global health epidemic. And this is within older adults. And he actually wrote a book that was published this past year that's exceptional if you really want to dive deeper into the topics. Right at the cusp of the pandemic, the National Academy of Science, Engineering, and Medicine did a really major kind of landmark report on loneliness and referred to it as a public health concern. So especially among older adults, even though it is prevalent throughout all age groups, this was an issue before the pandemic. And one of my great concerns is that once we've kind of recovered and we're out of whatever phase we're in now and on to the next one, that people will forget as things are opening up. We're all getting back into it. We've all experienced, and that's, I think, why it's been such a prevalent issue this past year plus, because at some level, we've sort of all experienced one or both of these things. It's becoming more prevalent among younger adults. And in fact, this 2018 study by Cigna identified, and this is across all age groups, so 20,000 adults in the US, give or take a little less than half reported feeling lonely, left out, and or isolated. About a quarter felt like people don't understand them. But, more than half said they did have meaningful daily in-person interactions. People who live with others tend to feel less lonely, but single parents feel more lonely. And for those who have experienced that in an aspect, you can probably understand that. This last bullet point is the one that it concerns me the most. The Gen Z generation, the 18 to 22-year-olds are the generation that, along with heavy social media users, are reported to be the most lonely and the least healthy. So this is something that's an issue across our the life spectrum, but we're here obviously to talk about it related to older adults. So as I mentioned, you can be lonely with people, but not necessarily lonely if you're alone. And I think that's an important piece. And as we think about this, and as providers and professionals, you think about how you might assess and intervene in it, you have to remember it's very individualized. And the estimates about prevalence among older adults is really kind of all over the place. It depends on who's been studied and how large the sample, but it's somewhere between a quarter and 60%, which is a huge range. But again, it sort of depends on how the questions are asked. We do know that the two issues, loneliness and social isolation, are very much linked. And what are the risk factors? Well, being isolated, certainly, having very few or no social activities, this living alone issue, which you'll see comes up again and again, and being unmarried or unpartnered. They're risk factors only. They're wait to find out what the predictors actually are. So thinking now about social isolation in older adults, what do we know about that? Well, we know it is linked to an increased risk for dementia. And we know that people who are socially isolated tend to be more stressed. They tend to have less access to and utilize less social resources, and they also have impaired sleep. So looking at, again, risk factors, being unmarried or unpartnered, being male, having lower levels of education and lower levels of income. And some of that has to do with being able to have access to other people in some respects. We do know that this costs Medicare and Medicaid a tremendous amount of money yearly. Medicare last report in 2018 indicated that they were expending about $6.5 billion a year due primarily to increased hospital stays because people were, in some respects, not being able to access regular health care, not utilizing the supports that might have been there, not having supports. So they intended to seek out hospitalization, emergency department visits more frequently. All right, in thinking about this for those who experience dementia, the studies have been coming out for several years, but there aren't a tremendous number of studies that look specifically at people with a cognitive impairment. I will say, however, that the research is exploding in the last year. The publications are just coming out every day. I just got one a few minutes ago while we were on the break, got one about loneliness in long-term care facilities. So I think we're going to start seeing a lot more of this, and I expect we also will see a lot more research coming out specific to dementia. So what do we know though? Well, as I've said, we know that it's linked to cognitive decline. We know that it's linked also to Alzheimer's disease neuropathology. Certainly being lonely and or socially isolated puts one at increased risk, as I mentioned. In fact, 1.64 times more likely to develop dementia. So I think those are some pretty significant things that we as professionals really need to be in tune to. We know that persons who live in communities and sorry, here, this is, I want to make sure I get this right. My screen is over. So people who live in the community and long-term care facilities are at an increased risk for loneliness, social isolation, and physical activity. And there's a link there with that physical activity piece as well. So looking at Lee and group just this year have published a study. They controlled for the physical health, social contact, and depression, but not cognitive status. And they found that people had higher overall social loneliness. And, you know, the recommendation from everyone at the end of all of these studies is we need to be assessing and intervening. But that's where the disconnect comes, and I'll talk about that a little bit more in detail. So I think one of the most interesting findings that has just been published this year is that persistent loneliness is an independent risk factor for increased dementia risk, and that's part of the Framingham study. And I'm sure everybody's familiar with the Framingham study that's been going on for decades. And the intervention can create resilience, and that was the part about that study that really caught my attention, because so many of the studies address this, but they don't really give us any guidance on, okay, what now? What do we do now that we know it's linked? It's a risk factor. We know people who have dementia have a particular, a different kind of experience with loneliness and social isolation because of the cognitive impairment. So I will come to some possible interventions. We cannot talk about loneliness and or social isolation with people who experience dementia without talking about their caregivers. And there's not much, as I said, there's not much out there on dementia in general, and there's less on what's the caregiver impact here. Anecdotally, I suspect any of you, any of us who have who work with persons with dementia and their caregivers, anecdotally, you've heard lots and lots of reports in the past year. I know through our St. Louis University Aging and Memory Clinic that my colleague Max talked about in his presentation. We meet with the people who facilitate the groups every week, and they talked at great length and very painfully about the stories that they heard from the caregiver support groups, talking about how isolated they were. And these were typically spouses who were caring for a spouse with dementia. And the stories were heartbreaking. You know, they hadn't seen their family, and the person with dementia wasn't getting any of the usual kind of stimulation connections. They were becoming quite stressed. So what does the research actually say about how this is all tied into the issue of caregiver stress? So if you think about the issue of stress in general, we all know that chronic stress can certainly then lead to one kind of withdrawing because it's just too much to deal with. You withdraw, that increases your risk for loneliness and social isolation, obviously. But that then triggers this neuroendocrine and neuroimmunological regulation, which can then begin to wreak havoc with your immune system and even cause low-grade inflammation. This kind of creates, as the slide here says, this symptom cluster. And once you've kind of gone to this part of the cascading kind of effect that occurs here, you really then are setting yourself up for risk of both physical, mental health kinds of issues, and the mental health ones include depression, sleep appetite disturbance, cognitive issues of separate from what we've been talking about, and then certainly comorbidities and mortality. So I think that it's imperative that we're addressing not only loneliness and social isolation in the person with dementia, but we're also looking at that caregiver as well. Caregiving can be a very lonely business, and can isolate as the usual support systems tend to withdraw. All right, so just a few recent updates, and I could not hardly keep up with them. I signed up for Google Scholar to get new publications that come out on a regular basis, and I get about 10 a day. So it's as I said earlier, kind of an exploding area. So surprise, surprise, I don't think anything on this slide will be of new information for any of us. Loneliness has skyrocketed. I mean, there's some reason to think that, particularly among older adults, that there's been a threefold increase in loneliness. We're starting to come away from that, thankfully, but during sort of the acute phases of the pandemic, a year ago, for instance, that loneliness and social isolation were just at really crisis levels, particularly for older adults. And think about the older adult with dementia who may not be able to sort of understand why this routine has changed, why the family's not coming, particularly those that are living in care facilities. So loneliness increased. 65% of people living with restrictions said they were lonely. There were some studies, though, which I thought were really interesting, that said there weren't any differences necessarily in the risk factors. So people who were at risk before were at risk now during COVID, but just in an exacerbated sort of state. Safety precautions certainly heightened loneliness. This quote I ran across from Dr. Murthy says, "During my years of caring for patients, the most common pathology I saw was not heart disease or diabetes, it was loneliness." So one of the takeaways that I hope everyone can leave today with is the knowledge that the impact of particularly chronic loneliness or chronic social isolation is far more significant than most of us ever realize. On that note, let's talk about specifically what are the impacts on physical, mental health, and then the utilization of healthcare services. This is a partial list, really on all three categories, but from a physical standpoint, sort of the major physical health impacts are increased blood pressure, depression, alluded to, weight gain, smoking, substance abuse, and alone time. Co-occurs with frailty, which again is kind of, you can imagine this sort of cascading effect of someone has some mobility issues, some health issues, they start to sort of withdraw and kind of make their world smaller, and they become more immobile, less active. And now we've got someone who's frail. Take note of the final bullet point under physical health. Loneliness is more dangerous to health than obesity and comparable to smoking 15 cigarettes a day. And we all know how devastating both of those things can be to your health. And to think that loneliness is as bad, if not worse, I think really sums it up better than probably any other statistics or findings that I can share. From a mental health standpoint, I've really kind of alluded to all of these from the perspective of certainly increased stress and depression and impaired cognition. So one of the most actually two of the most interesting studies I think that have come out just in the past year show that loneliness and social isolation is a risk factor for all-cause dementia, especially Alzheimer's disease, but in this one study, not specifically for vascular dementia. And then Sutton and colleagues found that there was a 40% increased risk of dementia. So, that makes us kind of wonder about some of the people that we all see in practices or in the settings where we work. Is some of the cognitive impairment we're seeing in some way tied to the loneliness and social isolation pieces? In terms of healthcare utilization, 50% increase in emergency department, emergency room visits, oftentimes more than 12 primary care visits per year for this population. So it's so inextricably linked to health and mental health issues that it's really hard to sort of separate all of that out. There's a study done in the UK that found that premature institutionalization was another outcome of chronic loneliness and social isolation as well. And that was a 10-year study. So they got really good long-term data from that. Steve Cole from UCLA makes this quote, and again, I don't know if you're seeing that in my, but it says, loneliness acts as a fertilizer for other diseases. The biology of loneliness can accelerate the buildup of plaque in the arteries, help cancer cells grow and spread, and promote inflammation in the brain. So he really is trying to make the point that we all need to be paying attention to this, I think is the takeaway there. Holt-Lunstad is one of the premier researchers in this area, and she and colleagues looked at 3.4 million people over a 7-year period who had reported being lonely, socially isolated, or lived alone. And looking at the linkages between that and one's increased risk for death, you can see here 32% of those who lived alone, 29% who self-reported being socially isolated, and 26% who reported feeling lonely were at increased risk for an earlier death. And the process, as you can see here from the graphic, that happens here is that when we experience this issue of loneliness, and this is sort of irrespective of one's cognitive status, it inflames the brain's white blood cells. It makes us then feel irritable and have all these negative feelings. Our brain starts to misread these social signals. People become threats. And then that distorts reality. Well, think about this in the context, actually, of someone who does have cognitive impairment already and who may be experiencing some of these things. You've compounded it now if they are experiencing loneliness. And one really interesting study that I will share with you, there was a study done in, albeit one nursing home, and they found that 100% of the residents in that facility were reported feeling lonely, 75% of them severely lonely. So not to say that all nursing homes promote that, but I think that, it's even just more evidence that we need to be thoughtful about how do people experience this. All right, so a few things we've learned from COVID. We've learned, not just during COVID, that there are things that actually do predict it. And you can see here, people living in rural areas sometimes end up being more isolated and lonely, particularly as younger adults. I'm from a rural area, so I know younger adults are sort of leaving rural areas in larger numbers, having functional status, that being unmarried, unpartnered again, being female, which speculatively might have something to do with expectations of relationships, sort of generalizing very broadly. But as you can see here, the 4 items that are highlighted at the bottom are the ones that are statistically significant and more predictive. So depression, that living alone piece again, feeling poorly understood by others, and being a member of the LGBTQ community. So these are the strongest predictors of loneliness. There's a slide on what we've learned from COVID. We've learned that relationships are important. And I think we all have seen and heard the stories from care facilities as well as people living in the community that they were trying to stay connected to their family and friends, and doing some fairly creative, high-tech, low-tech kind of things. But the reality was that what the past year has taught us is that these relationships aren't just nice to have, they're critical, they're life-saving to have. I participated in one webinar where a woman shared, she was a caregiver, and she shared photos of her spouse who had been living for several years, I think, in a care facility, and she wasn't able to visit him, and she had pictures that showed him over like the first 6 months of the pandemic, and the change in his physical appearance was startling. He, looked quite healthy, and he was had lost weight. He looked sad in the picture. So that was such an impactful visual kind of presentation to see the impact that not having connection with family was making. I think we've learned that we have to pay attention to people's needs and feelings. We all knew that before, but it's even more critical now. And then these other things, we all know those. We need to be healthy and exercise and get good sleep. But if you're experiencing this loneliness or social isolation, and that's tied into depression and mood and anxiety and fear for what's out there, what's been happening, those things don't happen in the way that we need to. We've also learned a lot about technology, and we've learned that you don't have to necessarily be high tech or very tech savvy to stay connected. But these are all lessons learned, and I think now that we're hopefully on the leaving side of all of this pandemic and the recovery period, that we can kind of think back and take those lessons learned with us. So as professionals who work with older adults, providers in healthcare settings and other settings, what's our role in all of this? Well, our role is to identify all of those things that I've talked about up to this point, and make sure those are being treated. So if it's a pain issue that has caused someone to not be as socially active or mobile as they were, if it's a sensory impairment, I think Max talked earlier about, if someone can't participate in CST, if they've got a significant sensory impairment like hearing, but those are the kind of things that make people start to avoid social situations if they can't hear in noisy, crowded places, for instance. Something like incontinence or, foot ambulation kind of issues, oral health issues, any of those things, which are all of those hopefully are treatable to some extent, that can play into all of this as well. I've already talked about the depression and the cognitive deficits making people withdraw from their usual activities. So what can we do? Well, we can make sure with the limited number of geriatricians that you learned about earlier that are available in the US, being able to get a comprehensive geriatric assessment is not as easy as it would seem, but we do know that a comprehensive geriatric assessment increases the likelihood of someone being able to have those issues treated and still be living at home, 6 months after the assessment. We need to be asking these questions. I'm going to offer some suggestions on how to do that. And we absolutely need to be communicating with family members, friends, caregivers, but also as a reminder here for people with dementia, we need to be assessing a caregiver as well. So we need to look at issues for the healthcare folks in the audience. We need to be making sure we're doing social prescribing and making those warm handoffs to the community resources when there are community resources to hand off to. I can't emphasize enough the need to assess loneliness and social isolation on a regular basis. Not just once, sort of at the first appointment or in an intake, but to continue asking because things certainly change over time. I think we all have a role that we can be playing at the community level to make sure there are resources there. And I want to also emphasize that there is considerable stigma attached related to the issues around being able to report that you are experiencing loneliness or social isolation. Both of those things are seen as indicators by most of us that something's wrong. I think the pandemic has kind of changed our perceptions, but I think for older adults, there's very much a stigma attached. So that's why it's important to think about how you ask the questions. And at the end of the day, for most people, including those with mild to moderate stage dementia, that people have a right to self-determination. So if they don't want to join a group that I'm going to talk about here shortly, then we have to respect that. We need best practices. We need evidence-based interventions that we know work, and I'm going to share one with you here. And can't say this enough times, whatever intervention you offer or suggest, really needs to be individualized to that person. One size does not fit all. There's some school of thought that, group interventions are better for people who are socially isolated, one-on-one interventions for people with loneliness. But I think, quite honestly, the jury's still out on probably both of those things, because just anecdotally from the work we're doing at St. Louis University, I don't know that I would support either of those claims. So what can we make sure we do? Well, we need to just ask the person, what do they want? What do they need? And what are you ready for? If we can keep those questions in mind, I think we can begin to address this. And recognizing, particularly as we're into hopefully the pandemic recovery phase, that there is going to be a lot of anxiety around, kind of re-entering the world and going back to some of those. I have two older family members who said they'll never eat in a restaurant again. I've said when I've given this variation on this presentation before, I said, I hope that's not true, because I think they really enjoyed doing that before, and hope that they can again. But there's still a lot of anxiety, I think, and particularly for people, again, thinking about the caregivers and the persons with dementia, that there's, they've been probably quite isolated for the past year. So now to have a whole nother kind of change can be disruptive, and there's been all this emphasis on what what terrible things are still out there. So I think we have to work with people where they are on that one, and just here's some suggestions on the slide for how to do that. Talking about gradual reentries and kind of figuring out what does a reentry look like? Do I go back to church? Do I go out to a restaurant? Some people are comfortable in certain settings, but not others. So it's just important, I think, for those of us that have the ability and the luxury of time to be able to have these conversations. It can be very helpful. So let me spend my last few minutes here talking about some interventions. And particularly for those of you that are in settings that you are either considered to be age-friendly health systems or that you are striving to be age-friendly. There are kind of 4 components to being an age-friendly health system, making sure that you would address the issues with the older patient of what matters: mentation, mobility, and medications. So I want to kind of frame some things around those. There's really 2 ways to assess. There's a number of scales out there, validated scales, one of which was in the Wheel of Fortune clues earlier. And I'll talk about those in just a moment. But there also are just single item questions where you just ask people open-ended questions. Take note that one study done in 2014 found that women were more willing to report feeling lonely if you just simply ask them directly, whereas men would be more forthcoming if you provided them with a scale, some kind of tool to ask those questions. We do know that loneliness among all age groups, genders, is very much underassessed. So, I've done this, been giving these talks for several years now, and I would ask for a show of hands, and most people are never asked about loneliness and social isolation. So thinking a little bit more to build on this 4 M's model that I just mentioned of the mentation, what matters, and there's a typo there, I never noticed that, and mobility and medication. So, there's lots of different ways to come at this. You don't have to have a loneliness measure, for instance. You can assess mood. You can look at social support. You can look at physical health. And they will address any of these issues. But again, the most important thing here is that you're getting at what matters to the individual. And in this case, where we're talking about persons with dementia, you're also looking at the mentation issue. So here is the Cadillac or the Mercedes-Benz of comprehensive assessments around loneliness and social isolation. And I am not naive enough to think that anyone has probably the luxury of time to be able to do all of these. But you certainly want to be assessing cognition, because that puts someone at particular risk. You've heard already about the rapid cognitive screen that was developed at St. Louis University as the shortened version from the St. Louis University mental status exam. That we know is a well-validated tool. And it also picks up MCI, as I think my colleagues mentioned. Depression and anxiety, certainly the PHQ-2 and 9, a general anxiety scale. These are just ones we recommend that we've had experience with. And then the Lovin Social Network Support Scale is a good one. It's a little lengthy, and I think but can be done very conversationally. The UCLA Loneliness Scale is sort of considered to be the gold standard of loneliness measures, and it's been validated on multiple age groups across a variety of settings. Happened recently onto the Social Connectedness Scale, which I really thought looked pretty interesting. Tied into all of this, you also need to be looking at someone's mobility because that, as we know, can be a real risk factor and a result of loneliness. So both, it's kind of that double-edged sword. Here's just some sample questions that I've collected about ways to get at this. The one that I actually like best, that I think will tell you so much about someone, is if you have good news or exciting news, who would you call first? That just tells you a lot about, and that can be a conversation starter, and you can then, kind of open it up to talk about some of these other things. It's important to just know how to approach your client or your patient, particularly, someone who has cognitive impairment. How are they going to respond? So you have to use your own clinical judgment there. Just wanted to share with you a copy of the Rapid Cognitive. It's quick, it's easy. I think Dr. Sanford mentioned it could be done in just a matter of 3 or 4 minutes. I've certainly seen it done that. All right, talk about interventions. Thinking about any kind of an intervention to address loneliness or social isolation, it has to include physical activity, cognitive stimulation, and if it's going to be a group or even a one-on-one kind of experience, it needs to be facilitated by someone who understands older adults with cognitive impairment, and comes at it from kind of this empowering perspective. My colleague and friend Philip Rosario, I thought, had this great quote. We talk about people aging in place, but they end up aging in isolation. And I think that's sad but true. So I'm going to run through just a couple of really quick, kind of fun sort of interventions. And this one actually comes to us from Africa. They created friendship benches outside of primary care clinics. They've been at this for a number of years now. They've served over 40,000 people, and they used lay trained healthcare workers called grandmother health providers. So it has sort of this dual purpose. They're serving older adults, but they're also utilizing older adults to provide the services. And they chat with people, and it's very low cost, but high impact kind of intervention. And there's a TED talk about it. It's had a lot of publicity. And to that end, in the UK, they have taken the issue of addressing loneliness as a society very seriously. In fact, they have created a ministry of loneliness, and they have a minister who heads that bureau up. And they are committed as a nation to address this issue. And so they've created chat benches that are, as you can see here, these are pictures of actual chat benches in the UK. And they publish an annual report, and they're starting to see some really interesting progress. The police departments have become involved, and they are just obviously clearly a non-clinical kind of intervention. So there's probably no evidence base to this, but it's something that a community could do very easily and inexpensively. Lots and lots is coming out now about the use of technology in the context of technology being used as a befriending service. And, befriending services have been around. Telephone check-in, telephone reassurance programs have been around for decades. But they really enjoy this increase and a kind of a renaissance during the pandemic. I know a lot of universities had students involved in doing phone check-ins with older adults, and with great success and real benefits for both. But there's a number of different kinds of technologies. There's, the more inexpensive ones that you can have, the Alexas that you can have in your home, all the way up to Pepper, who is an AI robot that's being tested both in Europe and in Japan. And that's probably a little bit out of our individual price range at this point, but who knows what the future might look like. Living arrangements have also been around forever, but there's a more purposeful sort of intentional kind of community approach to them that has gained popularity in recent years. The Golden Girls here is one, but they're the ones that are more kind of formalized. Picture on the bottom is actually from one here in St. Louis, where young adults, often college students, will sign up to live with an older adult, particularly an older adult possibly with cognitive impairment and or physical disabilities. And again, it provides benefit for both. And some of these communities are much more formalized than others. The arrangements are more formalized, but they're not for everyone. I think that's the important piece to remember, is not everyone wants to share their home or to have a young adult in the home. So, but I think that's the piece about we need to make sure that we're individualizing. So Circle of Friends is an evidence-based intervention. In fact, one of the only ones that we've run across. I mentioned earlier, it was developed by academics at Helsinki University about 20 years ago. And it is evidence-based. They are a prolific group of publishers. So there's lots of information out there that they've published. They have been gracious with us to adapt it for use here in the US. It's a group intervention. It's typically a group of 8 that meets 12 times over a 3-month period, facilitated by a trained facilitator. It doesn't necessarily have to be a professional or a clinician. As far as we know, this is not a reimbursable service, at least at this point, but the entire purpose of the group is to address and end loneliness. And the group has the intervention has 3 kind of really unique components to it that I'll talk about that are not part of the typical sort of support group that most of us are familiar with. But I want to talk first a bit about the evidence. So here are just 2 of the larger studies that they did. And they've trained over 750 facilitators and served over 10,000 older adults in the first 15 years or so of they're administering this intervention. So the first studies you can see here, 97% of people at the end of 2 years after they participated were still living, and that there had been improvements in health, decreased healthcare costs and hospitalizations. And one of the unique factors about this group intervention is that after the 12 weeks, or the 12 sessions in 3 months, the facilitator is supposed to be out of a job, and the group bonds and becomes self-sustaining and meets on their own. And you can see here that in both of these studies, about 40% of the groups did continue meeting on their own after the facilitator. So that's not your typical support group kind of model. 95% in the second study reported that they no longer felt lonely, and 45 to 85% reported making new friends, which is exactly the point. One of the studies, probably their longest term one, is they did a 10-year follow-up. And you can see here that 67% of the groups in this particular data collection effort were continuing to meet. 87% said they were no longer lonely. 70% reported that they found new friends. Those are very encouraging and very solid numbers, I think, for us to believe the evidence. So why does it work? Well, it's very, very client-centered, very patient-centered. It's one of the other unique features of this intervention is that the topics that are dealt with are determined by the group members themselves. So the discussions, the themes, the activities, all are generated from the group members themselves. And that sometimes requires a negotiation, as we've learned in our experiences. But that means now, though, that it is not a curriculum-based intervention. And that's disturbing possibly to some people who are looking for something much more prescriptive. So this does rely, make the facilitator have to rely on their own creativity in the beginning, certainly. But member involvement in the planning really does promote bonding, it promotes investment in the process, and it leads to a lower dropout rate. The photo here is one of our groups in the St. Louis area. The other unique component is that there are 3 issues, activities that get addressed during each session. Now, when we transitioned all of our Circle of Friends groups online during the pandemic, we had to decrease the amount of time because just, having people sit on Zoom, as we could all attest to today for long periods of time, is particularly for those that have cognitive impairment has proved challenging. So we've kind of done some alternative formattings for the virtual groups, but every session is supposed to include something that's art focused or inspiring, some kind of health related piece, and then a reflection piece as well. So I'm going to quickly talk about those. So art inspiring can be visits, it can be themes, it can themed discussions, it can be activities, it can be music. We have had graduate students who've been facilitating the groups for the last year virtually, and I've been amazed at what they've come up with. They did a virtual tour of the Louvre for one week. So group exercise can be, again, an outing. It can be chair yoga. We had somebody come in and teach breathing techniques, which then became a regular part of every group session. Again, you're really only limited by your own creativity as a facilitator and what the group members want to do. Therapeutic writing and sharing. We've learned that the writing part is not necessarily always completely embraced by all of our groups. So again, because there's flexibility and room for creativity here, we have kind of moved to maybe having some targeted questions where people can share. What our group facilitators, both in the communities where we've done the training and in our own clinic at St. Louis U, have been surprised. The facilitators have been surprised at the depth in which people have shared about their lives and how they feel. Once they feel safe in a group, they feel safe to reflect on their lives and their feelings about loneliness and social isolation. Who is appropriate? We've determined here, based on longevity in this country, someone 65 or older who acknowledge feelings of loneliness or social isolation, willing to participate. And then there's, of course, for the virtual groups, the telehealth issues to address. Have no visual or hearing or mobility impairments that would completely, eliminate the ability to engage. This intervention, not necessarily originally designed for persons with dementia, but the studies have shown over the years that those with mild to moderate cognitive impairment are certainly appropriate and can have meaningful experiences in the Circle of Friends group. So what do we need to be doing at the community level? Well, we need to be educating professionals. So thank you all for being here today to do this, because this is the first step. We need different kinds of approaches. It's not one size fits all, as I've said, but we also need as communities to be thinking about how are we segregating our older adult populations, and what can we do to address those issues? And we need evidence-based interventions. At the individual level, again, I've mentioned this several times, we need tailored, non-stigmatizing, meaningful kinds of activities for people. We need ones that include the physical activity piece, the mental health, the support, education, all of those things coming together. And older adults, who've participated in our groups say this is why they want to be part of these groups. And then we need to help people figure out ways to make those connections. And okay, this is one of my last slides. At the individual level, older adults with dementia have to be able to feel safe and heard and feel like that they can be in a group where people are interested in them and want to talk to them. So from the provider level, we need to assess, and then have some resources that we can offer to people. And I think one of the things that we've learned from the virtual delivery this past year is we will probably keep virtual delivery, at least, for part of the groups that we've done, because people have participated that would not have been able to do that otherwise. And we've had people from distances who've been able to log in. And then from at the societal level, we need to make sure we don't forget about this issue once the pandemic is over. A variety of resources. I know you're getting these slides, so I won't talk about them. The Circle of Friends has a wonderful website. Be sure you hit the translate button at the top, because otherwise you'll get it in Finnish. And we have a Circle of Friends page on our Gateway Geriatric Education Center site. ARP and other organizations that serve older adults have some great resources that I've run across. We've compiled a number of articles. If you really want to dig down and read all of the work that the group in Finland has done, send me an email. I've put a packet of 11 together that I can email you.